Thank you so much. Dear listeners, welcome to session 103 of the ECO sessions. This is co-hosted by Ministry of Health and that is the Emergency Department, together with our partners, SID Global Health. So today, the 24th of October, we have a session like no other, which is truly exciting. We have a wealth of practitioners, policymakers, and we also have a session or a speaker who is one of us in the medical fraternity, but from across the continent, that is in UK. So I would like to start the session by first of all introducing myself. I'll be your moderator. I'm called Dr. Sauda Namubiru. I'm a clinical microbiologist working with the Department of Laboratory and Diagnostic Services, that is Ministry of Health. I oversee antimicrobial resistance, a bit of sepsis, and diagnostic stewardship. With us is, like I said, a team of very very experienced, a wealth of knowledge, policy makers and practitioners. And I would like to first of all start with the the experts who are with us in the room. And then we shall also have our experts who are online to introduce themselves. So with me here is, I don't want to say her name, lest I say it in a way that she probably would say better. So I'll hand over to our first panelist. Over to you, Dr. Carol.
Good afternoon, ladies and gentlemen. My name is Dr. Caroline Achola, Assistant Commissioner, Clinical Pathology and Laboratory. I will be sharing with you the capacity we have in country in regard to managing a patient with sepsis. Thank you.
Thank you so much. Dr. Caroline has not told you that she's a pathologist, she's a hematologist, and she really has a wealth of experience and expertise in regard to the subject, but also generally as a pathologist. Thank you so much, Dr. Caroline. The audience is really eager to hear from you. Next, we have another doctor, Dr. Modesto.
Yes, thank you so much, Dr. Sauda. I am Dr. Odu Modesto. I am a microbiology resident at Makerere University. And I'm so happy to bring out one of the cases that is still ongoing and continues to be ongoing as we talk right now in the country. Thank you so much. And I'll be presenting with you the case.
Thank you so much, Dr. Modesto. Yes, Dr. Modesto is a medical doctor who is currently doing his residence in clinical microbiology. He's very enthusiastic about sepsis and he is one of our sepsis champions. Now online, we have Dr. Stewart. Dr. Stewart, over to you to introduce yourself.
Hi there, my name's Stuart Drazic-Taylor. I'm a microbiology diseases doctor in the United Kingdom in Birmingham. I've been working as an infection doctor for about 4 or 5 years. I have an interest in antimicrobial resistance, new diagnostics and tuberculosis as well. So thank you very much for the introduction and I'll be talking a little bit later.
Thank you so much, Dr. Stewart. Dr. Stewart has also forgotten to tell you that he's a public health expert and he has been to Uganda. So the choice was really point on because he has been to Uganda, he has been in the corridors of Kawempe, Mulago, and he really knows how the approach to a patient with sepsis should be in a country like Uganda. So please hang on and you'll hear. And then we are also blessed to have our dear Commissioner, Dr. Susan Navada. Dr. Susan, over to you. The audience is very eager to hear from you. Self-introduction. Thank you.
Thank you, Dr. Sauda. I'm Dr. Susan Navada. I'm the Commissioner in charge of Laboratory and Diagnostic Services the Ministry of Health, and I want to thank all of you for attending in such big numbers to listen to this big monster we have of sepsis. Thank you, Sauda, and over to you and our dear DJs almost.
Yes, thank you so much. So we shall be joined by our Director General of Health Services for Uganda. And as soon as he logs on, we shall be able to let
Sauda,
him.
he's on.
Oh,
He's on.
Okay. Thank you so much. Dr. Charles Solaro, kindly introduce yourself to the participants. Thank you so much.
Okay, thank you, moderator. A good afternoon, a good morning, or good evening to all of viewers, wherever you are, depending on your time zone. Let me just put my camera. Charles Solaro is my name. My place looks like a bit dark, but I hope you'll be able to see me so that you don't think that this AI.
Yes.
Thank you.
Yes, Digit, thank you. Thank you so much.
Oh, did you hear me?
We didn't hear the last bits. Maybe.
Oh, I'm saying I work in the Ministry of Health as the Director General of Health Services, and I'm happy to join to discuss on this very important subject of sepsis, or how we approach patients, because every other day facilities contend with patients with sepsis.
Thank you so much, DG. I think that I cannot say it better. That is how important the session is. The DG has logged on in person, and he will be telling us what the ministry is doing. The DG is also our national sepsis champion, and he has been involved in very many activities in the month of September just to talk about sepsis, to increase awareness, and we are very humbled and we don't take it for granted. Thank you so much, DG. So after the session of introduction, we shall have brief expectations from the participants, because we know when you log on, you have a particular expectation so that we can see if we are able to meet your expectations. So at this point, I'll call on a few participants to give us your expectations. Kindly put up your hand if you have an expectation, and then we shall be able to call on to you. Okay, I'll give it a few minutes. Yes, Brian Kasumba, please go ahead and give us your expectation. Yes, Brian Kasumba, give us your expectations. Kindly unmute and give us your expectation, Brian. Oh, as Brian comes on.
Okay. Okay. Now, yeah, I'm saying that I'm expecting to learn how to manage sepsis, patient with sepsis.
Oh, thank you so much. How to manage a patient with sepsis from Brian. Yes, Sarah Okello, and then Isaac Drachiri.
Yep.
Order. Yes, Sarah Okello. Akello, sorry.
Yes, thank you so much. Yes, please. Thank you so much for the opportunity. Yes, I'm expecting to know how exactly sepsis is being diagnosed in our settings in Uganda, as per the guideline, because we see in some settings people are confusing surgical site infection as sepsis. And then secondly, I would like to know, how is it reported to the ministry? Can it be reported in HMIS as sepsis itself, or there is a way it is being reported? And is it categorized by the group of patients, whether it is obstetric mothers, general surgery, neonatal sepsis? Yes, thank you so much.
Okay, thank you so much, Akelo. Those are very wonderful expectations. I hope we can meet them. Yes, we shall have Isaac, and then I think we shall end it at Hubert Nkabura. Apologies. Yes, Isaac, kindly unmute.
Yes, thank you. My expectation is how to identify this is a sepsis or any other condition, like signs and symptoms, to enable you to make a diagnosis of sepsis.
Okay, thank you so much. I'm getting in expectations in that chat. Please keep those coming. Thank you. Finally, let us have Hubert Nkabura, and then we shall dive into the session.
Thank you so much, and good afternoon, everyone. I'm called Herbert Nkabura, and I'm a clinician at Medical Research Council. So my expectation for this, presentation about sepsis is generally to know how to diagnose sepsis quite early before these other complications set in, and looking at the perspective or the context of the rural setting in Uganda, because we understand the rural settings we are talking about here in Uganda. And given the availability of different investigative capacities of such settings in the rural settings, and also the drugs available in such settings, how best can these lower health professionals in those lower peripheral health facilities diagnose sepsis quite early and be able to intervene using the resources they have. So into that context. Thanks so much.
Thank you so much, Nkabura. So we have taken note of the expectations. We are also still taking note of what is coming in into the chat. However, because today is a day with a number of commitments, we shall dive into our agenda for that day. And we shall start with the Director General, that is Dr. Charles Solaro, who will be giving us national insights and commitments on sepsis. And then we shall proceed. Over to you, DG. Our dear DG, you're welcome, and the floor is yours. Thank you.
Okay, thank you, and a good afternoon. How much time do we have for this session? Because
DG,
I wanted so that I can read to.
DG, we really
Is this
cannot
1
limit
hour,
you.
2 hours?
The session is 2 hours, but we
2
know
hours.
whatever you're giving us is really very important. So we shall be glad to let you take your time.
So thank you very much, and thank you, the Department of Lab and Diagnosis Services, for organizing this, and I want to thank all those who are logged in. So most importantly, this is part of the continuous professional development session, and I will be holding more others with time. And you know, this comes also at the same time as we conclude our Saturday's campaign against sepsis, and we really want to use this approach to be able to reach all of you. So sepsis is indeed a silent killer, and I'm sure that all clinicians, you have had your own experience with this. It's not a new disease. So yet sometimes it takes thousands of lives in our hospitals every year. Our newborns vulnerable operation. So it remains a major contributor of what we consider as preventable deaths in Uganda. And we have been attending safe motherhood. You find mainly the young people, those who have teenage pregnancy, unwanted pregnancy, then unsafe abortion, and then they end up with sepsis. So it causes maternal, neonatal sepsis, and then definitely death. So it ranks among the top causes of hospital mortality and morbidity, because So for every life lost, there's a family which is devastated and a health worker who is demoralized. So I'm seeing this as a growing threat, and definitely it comes with antimicrobial resistance, which complicates the sepsis. And nearly every 4 in every 10 patients who die of sepsis, definitely you are dealing with very resistant organisms. This means that even in our own, as clinicians, as recognized sepsis, definitely prompt treatment is key. And so we need to look at what are treatment options. So I'm looking at that this webinar provides that opportunity. So beyond clinical care, we also need to look at sepsis exposes definitely broader system weaknesses if we don't do what we call that small things and real necessary things like infection prevention, hand washing, emergency response diagnostics, early identification. But also we have to speak this in the context of the whole system, the supply chain, but also the referral chain. So sepsis requires the whole of system approach. It's not just only for the lab, it's not only for the clinician. So it is also include the aspect of communities. The community we need to be able to do one, to be able to talk about that. So at Ministry of Health, definitely we have aligned our efforts to the global sepsis agenda of 2030, and I'm proud to reaffirm our national commitments of reducing incidence of sepsis through strong infection prevention and control, wash interventions, safe childbirth. We would want all deliveries take place at health facilities and the rational use of antimicrobial. So in your facility, are these things which you are doing? Are you doing infection prevention? Are you having wash interventions? Are you having safe childbirth practices? Are you having rational use of medicines? Because whereas we are attending this webinar, but you need to take it in realities that there's a very thin boundary between us being providers and us ourselves being receivers of care. So if you cross the other side and then you are yourself a sepsis patient, then we need to be able to see how do we improve survival and how do we improve outcomes. But you can only achieve this if you do early recognition, timely antibiotic administration, which is definitely evidence-based. I don't want you to do just any antibiotic, but should be evidence-based, but also better emergency and critical care capacity across all hospitals. So reducing sepsis means that we have to invest in prevention, diagnostics, but also in standard treatment protocols. So as to minimize unnecessary investigation and delays and also complications. Because now, so as we speak of broader aspect of health system integration, even in sepsis, integrating sepsis awareness and control into our health programs, particularly newborn, emergency care, and microresearch and health security initiatives is key. So when we speak of each of them, we need to be looking at how are we integrating sepsis awareness, because prevention is really the way to go. So our commitment should translate into actions, and the actions is not that it's Minister of Health, it's you and me. And I'm looking at aspect of training of health workers on sepsis screening and management through this CPD. We would have loved many more people to have joined. It's one of our efforts, and I want to thank the session organizers and our partner, Seed Global, for this expansion of laboratory and microbiology capacity to support timely diagnosis. Antimicrobial susceptibility testing is the other mechanism. Integration of sepsis surveillance within the national AMR surveillance framework, but also strengthen the supply chain to ensure availability of essential antibiotics, IV fluids, and supportive care commodities. So it's really a much broader system issue. So it's not just only lab. So as a ministry, we have been working with partners, professional associations, including Uganda Medical Association, the Pediatric Association, the Critical Care Societies, to enhance continuous professional learning, mentorship, and the quality of improvement in care sepsis. So we need to be able to count and need to be able to identify them and account. So as I conclude, I want definitely call that to all clinicians and health workers gathered here today and who are listening to me, you are the first and the last line of defense for us to be able to either prevent, detect, and manage sepsis early. Sepsis should be treated like any other emergencies. It's actually an emergency, so early recognition saves life. So probably the team will be sharing with you what is the golden hour in terms of sepsis. I know in terms of trauma, but in terms of sepsis, what golden time? Because when the immune system of the body is overwhelmed, then almost all the other organ failures manifest. So let us ensure that every patient presenting with infection is promptly screened, treated urgently, and managed according to best practice. And that's the best practice why we think that we should be based on protocols. To our facility leaders, integrate sepsis audit into routine mortality reviews and the quality of improvement activities. To our laboratory professionals, continue improving diagnostic turnaround time and guiding clinicians with a timely culture results. Any results delayed is definitely a decision which has been delayed, and definitely it counts for every life. So we really would want that we get timely results, both for all the others, including culture results. And to our partners, we want to thank you for continued collaboration in building a resilient health system that can detect, treat, but also prevent sepsis effectively. Let us remember that sepsis should not be a death sentence. With awareness, vigilance, and timely action, we can reverse this trend. So let every health worker, let every leader, let every citizen be a voice against sepsis. Because every life matters. Let every voice speak against sepsis. So I want to thank again the organizers, and I'm looking forward to getting a feedback on what you want us to do together, but also at the same time, how we can be able to combat sepsis in the country, both in public, private, and private not-for health facilities. This definitely not applies only to the public health facilities. It cuts across all our health facilities. So thank you for listening. I hand over back to the chair.
A very, very big round of applause to our Director General. Like I said, he's our national sepsis champion, and I think you've heard it from his mouth. I cannot say it any better. But one thing that I will just re-echo from what he has said is, let every voice speak out against sepsis. So thank you very much, Director General. And because the Director General has been giving us the policy direction and the national commitments, we want to know if this is really a real problem that is happening in our hospitals. And at this moment, I will request our own, that is Dr. Modesto, to give us a case presentation to be sure that this really happens in our hospitals, or it is an imaginary problem that we are talking about. Over to you, Dr. Modesto. Thank you.
Yes, thank you so much, Dr. Sauda. Yes, as indeed the DG stated, we want to be sure that this is not AI, right? Okay, so today we are going to be giving ourselves an overview of a sampled case in the hospital. Okay, So we shall be discussing the approach to the patient with sepsis. Yeah. So the case today we are going to discuss is an 85-year-old male. He was a non-hypertensive and a diabetic patient who was referred from a peripheral facility. He had poor glycemic control and was on oral hypoglycemics. He presented with worsening loss of consciousness for 3 days, with worsening difficulty in breathing, productive cough, progressive body swellings, and a wound on the left leg for 1 month, which was reported 3 days prior to him being brought to Mulago. Okay. So in our primary survey, because we brought this, we want to know how we can approach any patient who has sepsis. So we have to look through quickly. Okay, so we'll follow through with the ABCDE approach, where A is the airway, and we want to ensure that it is patent or not. So in this case, our patient had a patent airway, but he had a reduced level of consciousness. So what was our plan? We want to monitor and maintain the airway patency. And we had to look ahead to see how is the patient breathing, okay? So the patient was in respiratory distress with nasal flaring. He had the use of accessory muscles of respiration, and he had the SpO2 or the oxygen saturation of 60%, and that was on room air, okay? So his respiratory rate was 23 beats per minute. He had wheezing and crackles bilaterally. And what was our plan? Okay, we had to institute oxygen therapy, which was being delivered at 10 liters per minute by a non-rebreather mask. Okay, and they instituted, or the clinical team instituted, salbutamol at 2.5 milligrams per 5 mils. Then we went on to the saturation. The patient had full extremities with edema grade 3, and a capillary refill was more than 3 seconds. Okay, the peripheral pulses was 67 beats per minute, to a thin and thready. The blood pressure was 87 out of 44, and the mean arterial pressure was 62. And we need to ensure that we have a mean arterial pressure of more than 65. Okay, this is very critical because this is a direct measure of organ perfusion. And in sepsis, we are directly ensuring that this is noted. You need to at least calculate your map from your blood pressure and then ensure that our organs are saved. The heart sound 1 and 2 was normal with no added sound. So what was our intervention to curtail this? There were several boluses of intravenous normal saline, 500 mils. They also instituted noradrenaline to ensure that we support the IV fluids. Okay. They ordered also for 2 units of blood, as we shall see or find out from our investigations, where this patient had anemia of 7 grams per deciliter, but this will come out later on. So we went ahead and did, the assessment of the disability. The patient had a GCS of 12 out of 15, and the pupils were equal, round, and reactive to light. Okay, with the RBS of 15 millimoles per deciliter. But however, the patient had no neck stiffness, no electrolyzing signs, and had no seizures reported by the caretakers. Okay, so when we go to the interventions that was instituted to bring the patient back, the patient was instituted on IV PISA, 4.5 grams start, then 2.5 milligrams, 12 hourly. I know someone will say, oh, but doctor, you're a microbiologist. Okay, this dose of PISA, why is it 4.5 milligrams? 4.5 grams instead, 4.5 grams start, then 2.5 milligrams every 12 hours. Yet it's supposed to be 4.5 grams every 8 hours. Okay, so we shall find out down that our patient actually had renal insufficiency. So in this case, even a microbiologist cannot compromise, okay? So this dose had to be lowered to cater for that. It was also instituted on IV metro, 500 milligrams every 8 hours, and supportive D50%, 30 mils every 6 hours. So when we look at the exposure, the patient was exposed and he had a temperature of 35 degrees Celsius. This is hypothermic, okay? And he had a necrotic wound on the medial left thigh with hyperpigmentation of both feet, okay? So this is what we noted, and we think that this could have been the focus of infection. This is where the infection actually started, okay? So what was done? We can note that there was wound debridement, which was done prior, okay, before the patient was brought into the hospital. But what we have to now ensure that is continually done is the daily wound dressing, okay? Because you don't want the microbial community to build back again. You need to ensure what you have yes, next slide, please. Yes, so after this primary survey, okay, this is now how you have approached the patient. You first want to have a critical aspects of the patient covered. After it was covered, now we took sample history, okay, or a quick history. So generally, in the signs and symptoms, the patient had a worsening loss of consciousness for 3 days with difficulty in breathing, a productive cough, progressive body swellings, loss of appetite, and a wound on the left thigh. So easy GCS was, or the loss of consciousness was deteriorating, okay? He had a marked respiratory distress with wheezes and crackles and a delayed capillary refill with cold extremities, had edema, a grade 3 with a thin 30 pulse, okay? And it was hypotensive. So these are the major concerns which were noted. But we know in sepsis, once we have allergies, then a patient can easily deteriorate very fast because these are immune dysregulations, okay? So you must actually be able to take a history of allergies. You need to know that the patient had no food or drug allergies. Then in the medication aspect, this was actually the medications that was already instituted prior to admission. The patient was put on ceftriaxone sulbactam, 1.5 milligrams OD with metronidazole, 500 milligrams TDS, and the other oral hypoglycemics, the glibenclamide, metformin, and also the hypertensive medications, amlodipine and Telvas-H. Okay, next slide, please. Yes, so the past medical history, we already noted this. I think we cannot understate it again. The last oral intake of that patient, we need to know that it was 4 days prior. So what were the events surrounding this patient's presentation and coming straight to, or leading to National Referral Hospital? So he was brought in from a peripheral facility. He was a non-type 2 diabetes mellitus patient with poor glycemic control. And this possibly was the first risk factor that brought in this case. Okay, so the poor glycemic control with worsening, then he developed a worsening, loss of consciousness with a progressive difficulty in breathing, generalized edema, and infected leg wound. Okay, so when he got the infected leg wound, it was initially actually managed from the peripheral facility. So his initial management, when it was brought into the hospital, is to institute oxygen therapy, IV fluids, and antibiotics. This is to curtail the emergency aspect. Yes, thank you. So after this primary survey, we need to ensure that we continually do a secondary survey. Now, this is going to be more detailed, okay? Now, this is where, you can have the normal clinicians coming in, and then, so on the relevant positives on the general examination, he was really a sick-looking elderly male. He was unconscious with this GCS dropping from 12 to 8, okay? Within the 3 days, the patient was in the emergency department. So what were the relevant negatives that we could look for? He had no histories of convulsions or no headaches or limb weaknesses, okay? that was actually not present in this patient. In the airway and breathing, he had wheezing with prolonged expiration, labored breathing, and SpO2 was 60% on room air, okay? And actually improved to 95% on the non-rebreather mask. So what were the relevant positives here? He had no chest pain, he had no palpitations, he had no auscultatory crackles initially, but this developed, we know that this developed later on, okay? So on the saturation, he was hypotensive with a blood pressure of 87 out of 44, with a 3D pulse, cold extremities, grade 3 edema, shifting dullness, hepatomegaly. So what were the important negatives here? We had no murmurs, no palpable masses. In the disability, we looked and found that the patient was drowsy, okay, with a reduced GCS. He had hepatic encephalopathy. He had a deep jaundice, okay? So the important negatives here was that the patient had his pupils were equal and reactive to light with no lateralizing signs or neck stiffness. And on exposure, this is where we found that, okay, now this patient has an extensive wound covering the medial thigh with a necrotizing fasciitis and hyperpigmentation and soil dressing with serous discharge. So this was our focus of the infection, okay? We had no signs of trauma or any facial asymmetry. Next slide, please. Yes, so in our investigation, what did we ask for? Or what did we find that the clinicians or the team had already instituted in place? They had already done an INR, which was 4. The ratio was 4. The D-diamonds was 1,000. This is actually high. We need to note that for our patients who are more than 50 years of age, okay, you need to multiply them by 10 nanograms so that you get the actual amount. So if we multiply that, our patient is actually 85. So if we multiply that by 10, gives us, I think, around 850. And if it is more than that, then you can now say it is high, okay? So this is very notable in our interpretation of D-dimers. We had to do C-reactive proteins, which was 10, but however, we were not able to do the serum procalcitonin, okay? This is a better marker of inflammation than CRP. And this is something that we could have instituted. Then we also need to note that we cannot talk about sepsis if we have not spoken about serum lactate. Why are we talking about serum lactate so much? Because serum lactate actually helps us in prognostic evaluation of this patient or the improvement of this patient. We can always see that this patient or our emergency management is improving if our serum lactate is decreasing, okay? So our dear partners, we need to have this at the back of our minds, and we increase our capacity to be able to do this in most of our facilities, okay? So going forward, the patient's random blood sugar was 15 millimoles per deciliter. We did a blood slide for malaria, and there were no malarial parasites seen. And his complete blood count had 15,000 levels of the white blood cells. Then the absolute values of neutrophils was 10, okay, with a HB of 7 grams per deciliter. So this is actually why we gave why we ordered for blood, okay? I think I remember telling us that this is what we would meet in the investigations. In the electrolytes, the patient was hyperkalemic, okay? The liver functional test, the ALT was raised, alkaline phosphatase was raised, which was 462 units. The direct bilirubin was raised as well. It was 6.07. So the renal functions, we did the urea and the creatinine. The urea level was actually high with a value of 597.7 milligrams per deciliter with a creatinine of those values. But we can note that the EGFR was 18.9, okay? So the patient's HbA1c was done, and it was 11.4. This is high. And this tells us that this patient actually had a poor glycemic control over the past 90 days, okay? The serum albumin was done, it was 2.57, and this is low, okay? What does this tell us? Now, if you evaluate the liver functions, the renal functions, and these derangements, this means that we already have our organ dysfunction setting in, okay? So in sepsis, you have to evaluate our different organs, and that's where you're going to pick out whether you're having organ dysfunction or not. But earlier on, colleagues, let's remember that we always have serum lactate done. If I do a serum lactate on you who is walking on the road, and I find that it is high, I need to immediately start giving you IV fluids, okay? So that is the first marker of organ dysfunction. But however, in the hospital, we are able to evaluate the patient through what I have just been mentioning, okay? Yes, now where does microbiology come in? Most especially now to identify, okay, to help identify the source of the infection. The things that we did was urinalysis coming in, culture and sensitivity of this urine, okay? But to note in the urinalysis was that we never had ketones. Why were we interested in these ketones? This is a diabetic patient, and we need to ensure that we don't have a DKA, okay? Though we really request and ensure that we be doing our ketones, especially serum ketone, would be the actual best test that we should have done. But I have most of our facilities, we are only able to do ketones in the urine, okay? The parcels were the +1, and there was no bacterial growth on this urine test. We are going to find out why or other issues later on. Thank you. Move forward. Yes, so on the blood culture, we picked 2 sets of blood from the patient. That was from the left antitubercle fossa and then the right antitubercle fossa. The A is the aerobic culture bottles, and then the B is the anaerobic culture bottles. We can note that we had only A1 flagging positive in 24 hours, okay? But A2, B1, and B2 were all negative throughout the 5 days, okay? So we had subcultured on a chocolate blood agar. There was a growth of 3 entire raised smooth grayish colonies. On McConkey, there was no bacterial growth. Then we did a gram stain, and we found a gram-positive cocci metal in clusters. So what were the tests that was done? We did a catalase test, and this was positive. This confirmed that for us, this is probably a staphylococcus, right? So we did a slide coagulase test, and then a MSA and a DNS, which was, the slide coagulase actually was negative, colleagues. Let's note that. This was not positive. I think the editing was not done well. And the MSA was negative and the DNS was negative. Move forward. So we did as well a pulse swab, okay? And how did it appear? It was moist and blood stain. On gram stain, it was gram-positive, we had gram-positive cocci in clusters and a +1 inflammatory cells. But however, when we strict it on the McConkey and the blood agar and chocolate, there was no bacterial growth, okay? Probably my take on from this is because there was already debridement done and they had instituted mupirocin, which was covering the wound. So this probably interfered with the swab that was, with the results that came out. Thank you. Move forward. So what was the differentials that came in? So we think that this patient was had a diagnosis of sepsis in septic shock with is a non-type 2 diabetes mellitus in DKA with diabetic foot. Why are we thinking of DKA? Yet we never had the ketones in urine. We have not done serum ketone, okay? So possibly we cannot dispute a DKA. We cannot rule it out completely, okay? So the differential diagnosis from this patient was that we had necrotizing fasciitis, possible CKD, uremic encephalopathy, electrolyte imbalances with metabolic acidosis, hepatic encephalopathy, and yeah, a number of other things. So I'm going to just highlight part of the management, but this was what was done on the patient. I know the part of management, I think, is going to be discussed by Dr. Stewart. So in the supportive care, we had oxygen and nebulization with salbutamol, and on the saturation, we had IV normal saline with noradrenaline infusion, blood transfusion of 3 units, renal support. We had to call for nephrology, and with all the nephrotoxic drugs, we will note that the patient was actually switched to mixed insulin. They removed off they removed off the metformin and then glibenclamide, okay? So the glycemic control was achieved with mixed insulin. Thank you. Next. So other parts of supportive management was IV omeprazole, because we had to, this is protective for our GIT system. And then we had the cardiovascular risk management, and they gave rosuvastatin. Then we had to escalate care. Based on all these presentations that came, the patient had to be transferred to HDU for neurocritical care, okay? This is a patient who is unconscious. We cannot solely leave this patient in the emergency department unless we can lose this patient. So had to get supportive care from the HDU. And we had to institute hourly vitals and urine output, plus other tests, things like renal functions, liver functions every day, okay? For all the 3 days, they had to be done. And these are part of the things that we need to know that we need to institute. Yes, then we had, of course, the multidisciplinary reviews, which came in, and we had the surgical review, nephrology coming in. Yes, thank you. More. So what were the systemic problems, oral targeted interventions? I think this is more of the same things that we had, but particularly we need to note that our patient was given a number of antibiotics, partly contributing to the negativity of our blood cultures and the negativity of the swabs. This patient was given IV PISA. This patient was given cefzalbactam. This patient was given IV metronidazole. Okay, so this is the targeted intervention which was given by the health team. Part of the other interventions I think listed there, but otherwise the most important part for me as a microbiologist is the first point, okay? Sepsis and necrotizing fasciitis management. Thank you. This was the follow-up treatment. I think we have already spoken about this, boss. We can just go forward. Move forward. Yes. So the disposition plan of our patient, okay? As we said, we had hourly vitals management. That is looking at the BP, the SpO2, the pulse rate, the GCS, and then of course the strict urine, the input and output of urine charting, the daily laboratory tests, the complete blood count, LFTs, RFTs, electrolytes, and glucose. This is supposed to be done every day. And then once you find that you have assessed your patient, you've done your, a quick survey, you have to stabilize your dynamics, okay? For example, if you find your MAP has reduced, okay, you need to ensure that you resuscitate the patient, and we have our MAP to come up to 65 more than. Then you have to control the infection source, and this is where you will have to instruct the team, and we have our nursing care to be adequate, okay? We need to ensure that we do proper wound care, and you have to support renal and hepatic functions, okay? I think we can note it from the management above that the team actually did do that. They have to do preventive complications, prevention of complications, for example, like DVT, hypoglycemia, and all that. So we had to escalate care, okay? If you have a worsening GCS, for example, our patient's GCS was 12, it reduced to 8. So this provided the criteria for escalation of care. With anuria, his urine output reduced to 300 mils every 24 hours, okay? the creatinine was high. So this showed that our patient was developing organ dysfunctions. Okay, so we had to escalate care and involve a team of specialists to review this patient, and it was done. Okay, and the patient was transferred to the HDU, which is a high dependency unit, and was managed by nephrology, surgery, and other physicians. So this is the pathway our patient took. But of course, we cannot just discuss this and not attach importance, okay, to a person's life lost. We lost this patient on the third day, and definitely this is a life lost to sepsis. Thank you for listening to me. At this juncture, I think I'll take the ball back to our moderator.
Everything was moving on smoothly until we had the last statement of we lost a patient. So this and many others is what patients, caregivers, and just like that DG said, the frustrations that caregivers and health workers and the patient families go through when at the end of all this, we say, sorry, the patient didn't make it. So I think to me that is a point of reflection that sepsis should not be a death sentence, but yes, it is a very dangerous and serious condition. And if not handled the right way, then we may lose the patient. And I'm just being told by Dr. Modesto that he was struggling to choose which patient to present, meaning there are many such patients in our hospitals, in your hospitals. So thank you so much, Dr. Modesto. I've seen quite a number of questions in the chat. The good thing is Dr. Stewart has attempted to answer some of them. For example, the person who asked about the coagulase negative staphylococcus, whether it was a significant pathogen, it has been answered in the chat. And then there was a typo, which has also been answered. And then there are some others that have not been answered. Maybe what is important is Dr. Modesto will tell us how bad the hyperkalemia in terms of figures it was. And then just somebody made a comment about the uremic encephalopathy being a big compound in this patient. Yes, we agree. And then, of course, the fact that it was a multidisciplinary management means that all of us in your respective capacities, including the administrators, are responsible. So I'm very sure if I let the questions come in at this point, we might preempt what is going to be told to us by Dr. Stewart. Like I said, this is going to be an E-word round. So Dr. Stewart, over to you. We are more than excited to hear you. I know you've been to Uganda, you've had sessions with us, and the health workers here at a total of 454 are excited to hear your great insights on this topic. Over to you, Dr. Stewart. Thank you.
Thank you for the very kind introduction. Just bear with me a second while I sort out some of the IT. Hopefully you now can see my screen and my slides, is that correct?
Yes, we can see them clearly.
Excellent. So I'm one of the infection doctors in the UK. I spent about 3 months in Uganda, spent some time at Kawempe, Malago Women's and Malago General Hospital. And I'm going to talk to you about what is sepsis, a very brief amount on the pathophysiology of sepsis, some scoring systems that can be helpful, a bit on the epidemiology and management. And actually, I won't really talk too much on antibiotic principles, just for time. With regards to, I'm going to talk about this from kind of a UK perspective using UK guidelines. We clearly have predominantly bacterial causes of sepsis. Clearly in your country, malaria may cause a similar picture, things like viral hemorrhagic fever. Clearly we see a lot less of that than you will. So this is predominantly bacterially focused. Just to recap very briefly on the case that was just discussed so well. I think the important thing to recognize is that they're presented to the best hospital in America in the United Kingdom, the likelihood of death in that situation is very high. So no matter what you do, as soon as the case was presented, that is a patient who's a very, very high risk of death, despite everything that you do. Okay, everything that can be done, that's a very high risk patient. And then I think it's important that we firstly identify that, manage it appropriately, and set, appropriate expectations with the family as to what is likely going to be the outcome. So what is sepsis? It's a very important and very good question. So in the top right-hand corner, you should hopefully be able to see research paper, which is from a large international group. And this is a very important research paper within the field of sepsis. And clearly, there will be many patients who present with a mild urinary tract infection, a mild chest infection, and they do not have sepsis. Sepsis should be defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So that means you have a severe infection, and your body's response to that infection is making you even more unwell. Some of you may have been aware of previous definitions which talk about SIRS criteria, which you can see in the box on the bottom right hand. It's a systemic inflammatory response syndrome. And the previous definitions essentially were SIRS plus infection, but that is no longer recommended as a definition of sepsis, and I will explain why. Firstly, the SIRS criteria isn't really a dysregulated response to infection. All of those features are somewhat a normal response and an appropriate response to infection. It's not dysregulated, it's not damaging. Many patients with other conditions will meet symptoms with inflammatory conditions like lupus, may have some of those criteria, but clearly they do not have infection, they do not have sepsis. The other important thing to note is many patients who end up on the intensive care unit with infection and organ failure did not score on those criteria, on those SIRS criteria. So when we think about sepsis, we need to think of infection and a life-threatening organ dysfunction. Septic shock is hopefully a definition here. Where septic shock is defined as a subset of sepsis in which there's profound circulatory, cellular, and metabolic abnormalities associated with sepsis. And some of these diagnoses are taken from intensive care guidelines where they're going to be using vasopressors such as noradrenaline. And essentially, septic shock is where you need some kind of vasopressor such as noradrenaline in order to keep your mean arterial pressure above 65, or a persistent lactic acidosis of greater than 2 after you have appropriately fluid corrected the patient and you've given them some fluids. And there is also a definition at the bottom if you're trying to communicate with family members, which can be useful to try and explain to them what is going on, essentially that you have an overwhelming infection where the body is attacking itself. This is a scoring system called SOFA, so the Sequential Organ Failure and Assessment Score. And I appreciate it's in quite a lot of detail. And to emphasize again, this is predominantly from an intensive care setting. So you may not have all of this relevant, the relevant metrics that you can measure on a standard hospital ward. But essentially, the point is that the higher you score on each of these different sections, the more unwell the patient is, the higher their SOFA score, the higher their risk of death, the higher their risk of prolonged hospital admission, and the kind of higher morbidity associated with this. So first of all, we have respiratory abnormalities, so essentially low oxygenation despite oxygenation correction. Patients become coagulopathic and get low platelets. They develop liver failure, which results in a high bilirubin. They need increasingly high concentration vasopressors in order to maintain a semi-adequate blood pressure. As sepsis progresses, there is a decreasing GCS and there is increasing renal failure and decreasing urine output, all of which are bad signs. I think some of you had mentioned in the chat about the Q-SOFA score. This isn't usually used within UK guidelines, but it's quite quick and easy to do. Essentially, if you're seeing somebody with a suspected infection, such as a urinary tract infection or a chest infection, you can use this scoring system. And essentially, if they meet two or more of these criteria, that is an increased likelihood that they may need a prolonged ITU stay or that they could potentially die in hospital. Probably the most important one is the low GCS. If you have an infection and a low GCS, that does suggest that the body is not coping particularly well with the infection. Having a high respiratory rate and a slightly low blood pressure probably is not as bad as having a low GCS. So I'm not going to talk in great details about the pathophysiology, but I think it's important to understand the basics. So within sepsis, you have a dysregulated inflammatory cascade that keeps going round and round in circles, and it's not able to kind of break that cycle. So on the right-hand side, hopefully you can see various different molecules that can contribute to the dysregulated inflammatory cascade that we see in sepsis. And the major thing that we see with sepsis is vasodilation and leakiness of blood vessels and capillaries. And that is mediated by various different molecules, including nitric oxide and bradykinin as well. And some of you may be aware of tumor necrosis factor, in particular TNF alpha, which is a very pro-inflammatory molecule, and this kind of sets this cascade kind of ongoing. We also do see dysregulated clotting. So thrombin gets upregulated, which can form small clots within capillaries. And this is why sometimes with sepsis, you will see disseminated intravascular coagulation, DIC, which is on blood test, you'd see kind of a raised INR, low platelets, and low fibrinogen if you're able to manage that. So the point to make here is this is an abnormal response to infection. This is a cascade that is not stopped until you deal with the infection, and this is damaging to the host. Because of the leakiness of the blood vessels, that means that if you give the patient IV fluids, less of that stays in the bloodstream, it leaks into tissues, they're at increased risk of pulmonary edema and what's known as third spacing. So it can be very difficult to manage these patients and their fluid status. I've also included a paper here on the global burden of sepsis and septic shock. It's obviously quite difficult to get accurate figures based on various different countries reporting, but there's about 11 million deaths due to sepsis worldwide based on 2017 data, and almost 50 million instances of sepsis. And as you may expect, there's higher rates in low and middle income countries in compared to high income countries. In higher income countries, we have maybe 500 cases per 100,000, whereas in lower and middle income countries, probably closer to 1,500 per 100,000. And I think it's important to note that even in high income countries, even with excellent ITU care and all the diagnostics that we have available, in kind of proper sepsis, the mortality can be up to 25%. And in somebody with septic shock, we can have kind of 30 to 40% mortality. And this paper goes on to say what some of the priorities can be for kind of managing sepsis from a systems level. So in higher income countries, we want to try and reduce the burden of healthcare associated infections. That's people picking up MRSA, Clostridium difficile, post-operative infections, joint infections, etc. We need to make sure that our sepsis management is excellent. And we also have challenges with an aging population. In lower income countries, while it's important to be cost effective in what you're doing, how can you get the best bang for your buck? In focusing on infection prevention and control is also important. And clearly in rural places, it's important to try and increase access to healthcare so patients present earlier. Clearly that patient that was discussed in the previous case sounded like they presented relatively late. If they'd come into hospital a week or 2 weeks earlier, then the picture may have been slightly different. We have very good and very long UK guidelines on the management of sepsis, which cover these various different areas. I'm predominantly going to focus on what's known as the Sepsis 6, but there's clearly other important bits. Human factors, if you're not aware of the term, is kind of interactions between health colleagues. It's about effective communication. It's about managing patients effectively, and making sure that we do everything that we should be doing. So even within the UK, which is a high income country, our mortality from sepsis is 20%, and we get 50,000 deaths a year. And if we think about that on the kind of global scale, it kills more lives than lung cancer, bowel cancer, breast cancer, and prostate cancer. So it's a huge, huge problem within our country. Whenever you're assessing a patient with infection, you need to think about what the risk factors for infection, for sepsis could be. So these are patients who are very young, or those who could be very frail, such as very elderly patients. If a patient is immunosuppressed due to chemotherapy, or have had their spleen removed, or they're on long-term steroids, you need to be extra cautious with them and make sure that you're working them up appropriately. If somebody's been pregnant recently or had a termination, you also need to bear in mind that there could be risks of sepsis associated with that. And with regards to neonates, if there's prolonged rupture of membranes, if the mother was group B strep colonized, if there was fever during labor, these are also increased risk factors for sepsis, and the child or the patient should be managed accordingly. The main important The main management step of managing sepsis is identifying patients with sepsis. So what we have is a national early warning system. So pretty much every hospital in the UK, on a standard kind of hospital ward, will have a national early warning score observation chart like this. So every time a patient gets a set of observations, their observations will get entered into a chart on the right-hand side, and it will get a score with it. Okay. And the higher the score, the sicker the patient, quite simply. The other thing when you're seeing these patients is you need to take a thorough history. So do they have symptoms suggestive of infection, such as fever, cough, confusion, urinary tract infection symptoms? Because you may have a high new score due to non-infective causes. And within the UK guidelines, there's very strict and very clear escalation criteria. So we should be screening patients for sepsis based on the guidelines at the bottom. So if somebody has a new score of 5 or more, they should be screened for sepsis. If the relative who brings the patient to hospital says they just don't look right, and you as a clinician think they look unwell, you should consider screening them for sepsis. If they've had recent chemotherapy or similar immunotherapy, they should be screened. And also, most patients, when they present to hospital, if they're unwell, will probably get a lactate on a venous blood gas. If their lactate is high, they will be screened for sepsis. The other important thing is with these national early warning scores, it also tells the nurses what they should do. So if a new score is 5, 6, 7 or higher, they will urgently call a doctor to come and see the patient. They're not going to be leaving this patient for an hour, 2 hours, 3 hours, 4 hours. If the new score is high, they will need an urgent review so the doctor can make a decision what should be done. We also need to think about the kind of red flag. So what would make us really worried about sepsis? So a new score over 7 or a new score over 5 with a 3 in one domain. So a 3 in one domain, just to jump back, would be, say, respiratory rate greater than 25, a blood pressure less than 80, essentially confusion. So if you've got a new score of more than 5 and a 3 in one domain, that should trigger you to worry that this person has sepsis. Other things on examination of the patient that should make you worried it could be sepsis, a kind of mottling of the skin, if they've got a non-blanching rash, if they're cyanotic. And another kind of useful criteria is if you saw them 2 hours ago and they look a lot worse now, then that is clearly concerning. If they've had some kind of recent operation, so they've had an operation and now they're a lot sicker, then clearly you need to worry about sepsis. And if they have a raised lactate or an acute kidney injury with any of the above, you should worry about sepsis. And if somebody is a high risk of sepsis or you're suspected it, you start something known as the Sepsis 6. And these are 6 interventions that have been shown to improve mortality from sepsis. So these 6 interventions we can see here need to all be done within the first hour. So you can't identify your patient as potentially having sepsis and then leave them for 2, 3, 4, 5 hours. This needs to be done in the first hour. Okay. The first thing we need to do is we need to get a senior doctor there. I appreciate this isn't always possible within every healthcare system, depending on if it's a night shift, etc. But sepsis is quite a complicated condition. If they have a urinary tract infection with an obstructing stone, then you're probably going to need to talk to a urology doctor. They might need a nephrostomy. If there's a heart infection, they might need cardiac surgery. These are quite complicated discussions to have. It's not really appropriate for a very junior doctor to be trying to drive that care forwards. If the patient has low oxygenation, we should give the patient oxygen. We're usually aiming for saturations over 94%. If they've got COPD or something like, if they're very large and they've got kind of obstructive hypercapnia syndrome, then we may aim for a lower target saturations of 88 to 92%. And clearly within sepsis, there's a dysregulation between the supply of oxygen and it being delivered to the tissues. All of these patients will need to have IV access and they will need to have various bloods taken. Within the UK, every person would basically have all of these done. I appreciate that when visiting Uganda, not all of these tests, such as blood cultures, are routinely available, but they are very important. Glucose is important for the reasons that were mentioned previously, such as they could be diabetic and DKA. We often also see hypoglycemia, so low glucose with sepsis, and that may be a reason why there is a low GCS. Lactate is very important. So it identifies something called cryptic shock. So lactate is measuring essentially anaerobic metabolism, which occurs when there is not enough oxygen deliverance to the tissues. Cryptic shock is essentially when somebody's blood pressure is not able to meet their requirements. And it's cryptic because it's maybe not obvious. So if somebody's blood pressure is 110 systolic, that's not particularly low. But if their lactate is 5 or 6 or 10, then that is concerning. And we may see that in patients who normally run a substantially higher blood pressure. If somebody's got known hypertension and they normally have a blood pressure of 200 systolic, a blood pressure of 100 systolic for them is extremely low and might be driving their lactate. If you gave them fluids and the rest of the sepsis 6, you may then find that their blood pressure rises significantly. All of these patients will need standard blood such as full blood count using and CRP. Liver function is also important, and clotting is important as we do see dysregulated clotting within sepsis. Clearly, if you're concerned about meningitis, you'll need to do a lumbar puncture. In your setting, we would always worry about malaria, so we could do a malaria rapid diagnostic test and blood films. A raised lactate is also important as it predicts the outcome and need for intensive care. With reference to the patient that was mentioned in the previous case, it's difficult to know, but I expect if you'd got a lactate on him as soon as he comes in the door, I imagine his lactate is probably going to be 4, 5 or higher. That was always going to predict a very poor outcome. And it's also important for guiding therapy because what we can do is we can measure the lactate, give the patient some fluids and see if it is coming down. If it's not coming down, that suggests a problem. We always need to give these patients antibiotics, particularly in the UK, it's predominantly going to be bacterial causes. There's a useful bit of information for you there. So 2006 study says that for every hour that we delay antibiotics, we increase the mortality by 7.6%. So if you identify somebody as septic and then you leave them for 5 hours or something like that, you're increasing their risk of mortality by about 35%. it is something we need to act on urgently and do urgently. We should ideally target the antibiotics to the source that we're kind of concerned about, but if you're not sure, then just give some broad spectrum antibiotic, which covers gram-positive and gram-negative organisms. Relevant examples may be coamoxiclav, which is amoxicillin and clavulanic acid, piperacillin, tazobactam, something like ceftriaxone. Those are all relatively broad spectrum antibiotics, and if you don't know what's going on, would be relatively appropriate. Clearly, we can refer to specific guidelines. So this is a pyelonephritis guideline, which is taken from the Ugandan clinical guidelines, and there's various antibiotics that we can see there. Clearly, if somebody is properly septic, then you probably are more likely to want to go for IV dosing, and you may want to go for higher dosing as well. Another important point to mention is source control, and that's something we always bang on about and always talk about in infection control and microbiology. If there is some kind of infection that you can do something about and the patient is septic, then we need to try and do something about it. So if you're able to drain the infection, if it's an abscess, or you're able to remove that, then we should do that whenever it's safe to do so. So with reference to the previous patient, if we were concerned about necrotizing fasciitis, then we could examine clinically for some of the relevant signs. So signs of necrotizing fasciitis are pain out of proportion. So if you squeeze the leg and very gently and they jump off the bed in excruciating pain, that suggests necrotizing fasciitis. If there's crepitus, which feels like you're kind of squeezing kind of bubble wrap and it kind of makes like a crackling noise when you squeeze the leg, that is suggesting tissue destruction and necrotizing fasciitis. If there's kind of purpura or kind of almost like buboes kind of thing, that also suggests necrotizing fasciitis. The management of necrotizing fasciitis is urgent debridement. So if we think it is that, that person needs to go for an operation to basically cut away the dead tissue straight away. If you don't do that, the patient's not going to survive. Even if you do that, the patient is highly likely not to survive. So no matter what that was done for the previous patient, it was highly likely they were going to die anyway. But clearly we need to identify the sepsis and try and do as much as we can within the remit of your healthcare setting and the resources that are available. Other examples of source control here. So if somebody's got urosepsis with a hydronephrosis due to an obstructing stone, if you don't do something about that blocked kidney full of pus, they're not going to get better despite how many antibiotics you give them, despite how much fluids you give them. They will need an urgent nephrostomy or some kind of operation to remove the stone, or they won't get better. If somebody's got a perforated appendicitis, you don't just leave them on antibiotics, you need to remove the appendix. You need to wash out all of the essential fecal matter that's in their abdomen, and then they may start to improve. If somebody has cholangitis, such as inflammatory infection of the biliary tree due to an obstructing stone within the common bile duct, you need to perform an ERCP, an endoscopic procedure, in order to remove that stone, or they're not going to get better. I appreciate that all of these things you may not necessarily be able to do, but that's how we kind of think about managing infection. Clearly, some of these patients are going to need, some kind of imaging, such as an ultrasound or CT scan, in order to be able to identify these specific types of infection. IV fluids are really important. So crystalloids are the preferred resuscitation fluids. So that's things like Hartmann's, plasmolytes, normal saline. And what we're trying to do is correct hypovolemia. We're trying to essentially improve the patient's observations. And we need to be very careful about pushing the patient into overload. So as we mentioned before, all the blood vessels within sepsis are very, very leaky. So there's a risk that if you give them too much fluid, it goes into their lungs and they develop pulmonary edema. That's a particularly increased risk if patients who've got heart failure or are very elderly. These are the various different fluids that you can theoretically give in sepsis, and I'll explain why some of them are appropriate and some of them are not appropriate and what you need to be aware of. Hartmann's is pretty good resuscitation fluid. The thing we need to be careful of is that it contains potassium, so if somebody's hyperkalemic, it would not really be appropriate. It also does contain small amounts of lactate, so you need to be careful in your liver patients. Sodium chloride is what we would typically use, but you do need to be careful if you're in high volume, so 2, 3, or 5 liters over a prolonged period of time, as due to the high chlorine content, you can get a hyperchloremic acidosis. Clearly, you're only going to be picking that up if you're doing venous blood gases, which I appreciate may not be available within your context. Dextrose is not an appropriate resuscitation fluid. We should never use dextrose for the resuscitation of sepsis. You may need to give them some small amount of dextrose if they're hypotemic, but we should not be using it as the main resuscitation fluid. It does not stay in the intravascular space. It's an increasing risk of causing hyponatremia, and just the fluid will leak out into the tissues. Colloids we don't really use, as it can cause acute kidney injury. If somebody is a known cirrhotic, we may consider using things like albumin. And if somebody is very anemic, then we may consider using red blood cells. But we wouldn't usually use red blood cells as a kind of standard resuscitation fluid unless they were anemic. Clearly, there's a lot of potassium in red cells as well, so you would want to be very careful if the patient was hyperkalemic. The National Institutes for Clinical Excellence is kind of UK guidelines on pretty much everything. So essentially what they're saying is in a patient with sepsis, we should basically give them 500 milliliters of whatever crystalloid you have available, such as normal saline, as quickly as possible. So that's 500 milliliters of fluid. As soon as you've basically got the cannula in, give that stat, okay? There is also a suggestion that we can give up to kind of a max of 20 milligrams per kilogram. So in an average 70 kilogram patient, that will be roughly about 1.5 liters, okay? So what you could do is give a 500 milliliter bolus of fluid, recheck their observations. If their blood pressure is still low, if they're still tachycardic, if they're still confused, give them another 500 mils. Do the same again. If everything's still bad, give them another 500 mils. At the point you've given them that 20 milligrams, 20 milliliters per kilogram, if they're still hypotensive, tachycardic, and have not improved, that point in time is where you need to start thinking about escalating to HDU and ITU if that is appropriate, or doing something else, because further fluid resuscitation may not necessarily be helpful. And clearly, as we've mentioned before, this needs to be done within the first hour, and we need to give 500 milliliters within the first 15 minutes. When you're trying to think about sepsis, what you need to do is make sure you do the first fluids fast. So you can worry later down the line about how much fluid they're going to need in the next day, 24 hours. You just need to make sure that you try and give them the first fluids fast. The second set you can kind of give a little bit slower if things improve. And you need to make sure that you've done the rest, so the IV fluids, taking blood cultures, etc. As we mentioned, we need to assess responses. You can't give them that 500 mils of fluid, then leave them 4 hours and not bother to check if it's made any difference. You give them the fluids if they look septic, and then you check again after the first fluid bolus. If things suggesting overload, so they're starting to get respiratory symptoms, you get a repeat chest x-ray and it looks like pulmonary edema, then you're going to need to talk to critical care because they're in a very difficult balance. If you've managed to give them some fluids and everything has improved, their blood pressure is much better, then you can give them some maintenance fluid, which may well be an 8-hourly bag of Hartmann's or normal saline or something similar. Clearly, each case is going to be different, and you need to analyze things on a case-by-case basis. If somebody has significant cardiac failure, you may decide to give a 250 ml bolus, assess, another 250 ml bolus, and assess. Likewise, with renal, with a patient on dialysis, you may not give them that much fluid as quickly. You may give them small amounts and check more frequently. So these are the sepsis 6. So you need senior help. You need to give oxygen if required. We need to get IV access and bloods. You need to give IV antibiotics and source control. We need to get IV fluids, and we need to monitor the patient. So we can't just do the sepsis, do 5 of the septic 6 and then just leave the patient overnight. If a patient is septic and we've done everything else, you're going to need to get a night review for them. You're going to need to get a weekend review if it's a Friday or something like that. They need to be checked on regularly because these patients can deteriorate in the night and then become very unwell. So just to kind of summarize, so sepsis has a high mortality. We need to urgently identify the patients who may have it. To urgently instigate the sepsis 6 within 1 hour. Patients need enhanced monitoring. That means regular observations. If you have scoring systems, use your scoring systems. If nursing staff have escalation systems, we need to use those. We need to make a very quick decision about if somebody's going to need HT or ICU support. That patient case that was discussed previously, you could tell straight on admission that person's going to need ITU. As soon as their GCS is kind of 8 on presentation and their blood pressure is as low as it was, that person is always going to need ITU, and that patient is always going to unfortunately do very poorly. Source control, if it's possible, needs to be done urgently. We can't leave this until a few days later, 3 days later, 4 days later. We need to try and do that as quickly as possible. Thank you very much. That's everything I've got to say. Back to the moderator. Thank you.
Wow, wow. I think that is, I don't know how to say it, but I think that is truly exciting. It is excellently done. Dr. Stewart, we can't thank you enough. We are very, very excited that you are able to join. We know that time zones are very different. We do not take your commitment for granted. Dr. Stewart, the Ugandans are very excited. They're asking for your personal number because they are very excited
I
about
saw that.
knowledge. And for those of you who have not interacted with Dr. Stewart, for some of us who have interacted with him, he's such a great teacher, but he's also a very excellent clinician. So thank you so much, Dr. Stewart. Colleagues, healthcare workers, I think you have heard. He has said so many things, I cannot even attempt to repeat them. But one thing I know is, and very relevant to this session, is in his management, he took us right from what is sepsis, how you identify a patient with sepsis, and the management. So thank you so much, Dr. Stewart. I know there are so many questions in the chat, but I think he has also made a very, very deliberate effort to make sure that he answers the questions. Some of these insights are from the UK, but trust me, they are not different from what is recommended for even countries like the low and middle income countries. And something, maybe a few issues that I can just re-emphasize is sepsis can come from any pathogen. It could even be malaria. And that is why when he's talking about the bloods, it's not specific to just take off maybe blood cultures, but also he talked about the sepsis 6, or the 6 points in the sepsis bundle. And I think, if I'm not mistaken, number 3 was talking about getting IV access and also ensuring that you take off the bloods. So the bloods are for many reasons, and I don't want to preempt the next session, but at least we have seen. And then maybe finally, and a statement that I really have borrowed from him, but maybe in a simpler term, is sepsis is not just a systemic inflammatory response syndrome, which is the SARS, because it can occur even in patients who do not have sepsis, but it is simply a life-threatening condition where the body's reaction to infection is out of range. So in short, the body begins to attack its own self. So if you relate it to common things with us, if it is soccer, the body begins to shoot itself in its own goal. So that is very, very important about sepsis. And the body attacking itself is the reason why we have to do whatever we do, because it is attacking everywhere, it is attacking its organs, and that is why we have to support it. And then finally, he says time is very, very important. Even with the best care, if it is not recognized early, you're bound to lose the patient. So that means time is of the essence. You have about 1 hour to do many of the things that you have to do, but the beauty is they are doable. So thank you very, very much, Dr. Stewart, once again. There are enormous questions in the chat, and I know people are aching with questions. However, it is the time is may not be enough for us to take the questions and then have our last presentation. So at this point in time, allow me to invite none other than our Assistant Commissioner in charge of laboratory and pathology and laboratory services. I think he's she's the best person to tell us whether we have the capacity, what can we do when we have this, and where can we get this capacity in this country. So over to you, Dr. Carol, to tell us what and where we can do when it comes to diagnosis for sepsis. Thank you so much, and we are eagerly awaiting Dr. Carol. Thank you.
Thank you so much, Dr. Sauda and team online for your commitment to this cause. I know we've had a presentation from the case that was shared with us, and we've had the presentation from Dr. Stewart on how to manage a patient with sepsis. And now I think it's time to discuss, do we have the capacity? Are we talking things that are out of reach? Or do we have the capacity to even diagnose sepsis and manage it in our health facilities? So once again, my name is Dr. Caroline Achola. I'm going to be taking you through sepsis diagnostics and the capacity of our laboratories across our networks to diagnose and monitor a patient being managed for sepsis. Next slide. So like we've had in sepsis, every hour counts. So early diagnosis is very important as it's what stands between life and death. And sepsis is a major cause of really preventable mortality. There are reports that not up to 60% of mortalities in certain programs in the country. So it's very important. And then diagnostics are central to early detection, management, and even surveillance. So next slide, please. So why do diagnostics matter anyway? Again, we've heard from the previous speakers that early recognition improves patient survival greatly, and diagnostics really guide targeted therapy and reduce misuse of antibiotics. So better diagnostic capacity will help combat complications that arise from sepsis, death, and ultimately antimicrobial resistance, which is an impending threat currently. So timely lab confirmation supports rational clinical decisions. In the diagnosis and management of sepsis, the lab remains central. And what is the role of the lab? Early recognition and screening, and then initial laboratory investigations. And then we move to pathogen detection and identification, including source localization from Dr. Stewart we've had. Antibiotics alone is not enough to manage. You need to identify the source and remove or clean up the source as you continue with your treatment. And then we'll continue monitoring this patient in the immediate post-diagnosis period, but also overly as they are in care. So next slide, the lab remains central. So what are the early recognition tools that we use? Well, like we've had, the first important thing is to identify who is a potential patient having sepsis. So when you do that, then we also go to the vital signs, the ABCD that we've heard about. Then we have scoring systems that are frequently used, the SOFA or the NEWS2 scoring systems that define the severity, whether it's sepsis and the severity of sepsis. And then we also have point of care lactate measurements that are widely available in our laboratories across the country. Our challenge has been that some facilities, a good number of them, have limited lactate testing outside of referral hospitals. But like I've said, we have a number of facilities now that are getting point of care lactate measurements that we can actually use outside the large platforms that we've known. Next slide. So what are the biomarkers in sepsis? We've heard about lactate. Lactate is produced in a state of hypoperfusion, and it directly, gives you how much hypoperfusion or compromised circulation a patient has. So it will tell you the severity and also is an important predictor for mortality. And then the procalcitonin that differentiates between bacterial or viral or even non-infectious causes in the patient. And we have the C-reactive protein that is also widely available. It's a common mark of inflammation, but very important when used together with procalcitonin in predicting a patient who has sepsis. And then lastly, almost all our health centers from Health Center 4 and some 3s do have complete blood count machines that we're able to tell. Actually, in training, that was the first that we would be taught to flag you if a patient has sepsis. Leukocytosis, or predominantly polymorphs, is very suggestive of sepsis, but also patients with leukopenia are at high risk of getting septic. So we also then do pathogen detection and identification. We have blood cultures, which are the gold standard. And I'm happy to report you that we have more than enough. So if you're in need of blood cultures, please reach the center, the microbiology team at the Central Public Lab to support you. We culture a number of other specimens too, not only blood. We can culture urine, we can culture CSF, pus, and sputum from patients suspected of having sepsis in our workup. And then antimicrobial susceptibility testing. Commonly, we have the DISC method, but also now we have automated systems that have been deployed in our regional referral hospitals and our national referral hospitals that are faster, that help you make faster decisions in starting your treatment. And then also we have PCR panels. We have a lot of gene expert penetration across the country, but also the PCR panels are available, and they have expanded our use in identification of the causative pathogens in our patients. And then not forgetting imaging and diagnosis in localizing infection. We can do a chest X-ray and you're able to identify whether that patient, the focus is in the chest, whether you have pneumonia or empyema, or you can also do ultrasound scans that are able to show you foci of abscesses or obstruction in the biliary tree or appendicitis or any other complications that may be the source of infection. And then, of course, we have other higher modalities of imaging. We have CT scans and also echo for cardiac patients and also for deep-seated lesions like the brain and other chest symptoms. Next. So in our monitoring of our patients, we have had in the patient that we presented, there was a critical period where we're doing a lot of monitoring in terms of the organ functions, but also serolactate levels, which directly indicate whether we are having an improvement in our perfusion. And then also the arterial blood gases. These are quite used frequently in our high dependency units, but also in the ICUs and in higher level facilities in our national referral hospitals and specialized centers. And then also we can do coagulation tests to detect early DICs in patients with sepsis. Next slide, please. So, so a focus on the specifics that we have in country. So at the national level, and that is the Central Public Health Laboratories, the department of the unit of microbiology, and the national referral hospitals, we are able to do culture and sensitivity on bigger platforms, molecular platforms that have a faster turnaround time. And then in the regional referral hospitals and district hospitals and selected health center force, including PNFPs and private for-profit, we're able to do blood cultures and antimicrobial susceptibility testing with automations. The Vital and the Phoenix are available. And then at district level, we are still doing microscopy, and we note that we still have limited capacity to do cultures. Next slide, please. And then, of course, noting there are still gaps as we respond to this very critical challenge. We have limited infrastructure at all levels of care in different areas, but also for a while we had a delay in blood culture results. One, because of the nature of the lab tests that take a longer time, but like I said, you can work very closely with the team at the center and flag for patients that are very critical. We have platforms that are able to give us results faster. And then also more than just the infrastructure, we also have inadequate antimicrobial susceptibility testing capacity in terms of gaps in training and mentorships that are being actively worked on to make sure that as many facilities as possible are able to respond, especially the district hospitals and high volume health center that serve bigger catchment areas. And then the minimal rapid diagnostic, we note that we don't have a lot of that, so we still have to rely on the conventional one that quite take a lot of time. And then sometimes we've had gaps in sample transportation and feedback for some tests. The sample transportation has been built a lot around HIV/TB response, but we've since opened it up to make it an integrated sample transportation network. And it's work in progress. We keep improving, and this platform gives us a lot of opportunity to interface with the team that are in clinical care, and we take your feedback and your challenges so that we're able to support you appropriately. Next slide. So what is a proposed diagnostic roadmap in sepsis? So we have the short term, really, which we are looking at providing as much screening as possible, screening and triaging patients through use of the lactate, serum lactate. But also in the medium term, we hope to reduce the culture turnaround time via automation. Like I've said, the higher level facilities and the central public lab have already got newer platforms that are able to give you results in a shorter time. So that is the direction that we are going. And with time, we are going to have a more smooth diagnostic process in terms of sepsis management. And then we also have some long-term proposed roadmaps that look at integrating rapid diagnostics into the essential diagnostic list for the country, for facilities to at least be able, to screen and assess your patients early enough and refer appropriately where you think the capacity you have is not enough. And then also to share with you, we have ongoing national actions against sepsis. One of them is integration with AMR surveillance that has already, as the discussions have started, and we've started to mainstream it. And then we also have rollout of the WhoNet and other labwares that are global platforms where we can get data and analyze data for sepsis and antimicrobial data. And then, of course, we are still supporting with standard operating procedures for sepsis specimen handling, and then expansion of blood culture capacity to district levels. And lastly, but not least, also we're working on the sepsis indicators for lab, and we are incorporating it into the monitoring and evaluation framework at the department to be able to inform us of the strategies that we need to adopt. And then lastly, this is a call to action. Sepsis is a medical emergency. We've heard in all the speakers who've spoken before that every minute counts, every delay impacts directly to the risk of that patient dying. Diagnostic saves lives when applied early and appropriately to the patients that require them. And then strengthening lab clinician interface and collaborations. A lot of times what we do in the lab, the clinicians are not aware. We sometimes have expiry of supplies for diagnostic kits because they are not requisitions. And when you try to follow through, they are not requisitioned because the clinicians are not aware that the laboratories where they are able and have capacity to provide that service. So strengthening the laboratory clinician interface is very key. The lab and the clinical team must always be in constant conversations and communication regarding the patients they are caring for. And then still a key call to action is to invest in diagnostic infrastructure and workforce across all the different levels of care across the country. Thank you so much. I think this is, over to you, moderator.
Thank you so much. It is at this point that I get to officially tell my boss that thank you so much. You have really nailed it in simple terms. Thank you for giving us where the country lies in terms of diagnostics for sepsis. Many of you have been wondering what happens if I'm in a health center 3, what happens if I'm in a health center 4, and what do I have to do? Do I just sit back and say I shouldn't diagnose sepsis? And I think she has clearly put it out to us that you do what you can. And maybe also to note that although we do not have a standard sepsis guiding manual, at least we have bits and pieces in the Uganda clinical guidelines. But with the current ministry commitments, as we heard from the DG, we are yet to develop a sepsis management manual. However, at least she has told you that if you're in a health center, we identify if you think the patient is at risk or likely has sepsis, then you can follow the chain of referral. And then in each of the levels, she has told you what you can be able to do. And if you can't do it, we have a robust sample transport and result dispatch system that can get you results. And oh, by the way, my boss, please allow me to tell the audience that we have blood culture bottles that are available even for private facilities. If you have a private facility and you need to diagnose, I mean, these are all Ugandans, and because you're very important contributors to healthcare, the Ministry of Health, that is the Permanent Secretary, the Minister, the DG, have seen it very important to extend blood culture testing to all facilities, be it private or government, so that we can be able to combat this monster and save every life. So if you have any need, kindly reach out to the team at the Central Public Health Laboratory or reach out to your nearest health center, regional referral health center, so that you can get the details. Or better still, you can refer the sample, or you can call any of us and you refer the sample to us, and then we shall be able to work upon it and give you a result so that you can be able to save a patient. For most of these other samples or tests, then we can do that. Then she has also told you about the PCR platforms. Yes, Uganda is one of the very few countries that have a biofire. Now, biofire, the way the word sounds, it is really diagnosis, but on fire. In simple terms, it gives you a result within the shortest time possible. Within 24 hours, if the blood culture has flagged if the blood, you put the blood culture in a machine, and if it has detected there is a bacteria, then it can tell you which bacteria it is within minutes. So that is also available. And remember, this test is extremely expensive. It's about 300 to 400 USD. So it's currently only at the Central Public Health Laboratory, and it is, or CPHL, and it is reserved for critically ill patients, where like sepsis patients, of course, are critically ill. So when you need to make a fast diagnosis of what is this bacteria, virus, or fungal that is affecting this patient, then please reach out to me or my team through the commissioner. I will allow that I give my number to the listeners because this is very important. My number is 0704 518351. It's going to be put in the chat only for sepsis and microbiology-related services. But well, thank you so much for listening in. And also to re-echo again, just before we take on the questions, is maybe one or two questions, is diagnostics are important if applied early. So please don't delay, otherwise you just do a diagnosis for postmortem. So at this point, I know the time is fast spent. I will allow a few questions so that we can be able to close the session. You can just raise your hand, and because we don't have a lot of time, we shall take on the questions as they come.
There was a question.
However, most of the questions have been in the chat, and I'm going to ask Dr. Modesto to respond to just maybe two questions, and then Dr. Stewart can also respond to two questions, and then my boss will respond to also two questions in the interest of time.
Yeah. Yes, thank you very much, our moderator, the sepsis champion. So there was a colleague who asked about the levels of hyperkalemia. This particular patient that we had at a level of 5.5 millimoles, this was actually raised. And you need to remember that the normal range is 3.5 to 5, okay? At this juncture, I want to, because I am seated next to the bosses who has talked about the Ministry of Health actively, supporting surveillance. I want to extend, a word and say that we are actively doing antimicrobial resistance research programs within our dockets at Makerere University, and we would actually highly welcome the Ministry of Health if they can, support some of these research activities, because we will generate very useful data that can be used by the ministry to inform decisions. So these are actively ongoing things, and probably my boss, I know our bosses are online and listening. Yes. So probably through Dr. Sauda, we can have something coming up for us. Thank you so much.
Okay, thank you so much. I don't know why he chooses to skip the boss and go through me, but our boss has heard. Thank you so much. Yes, Dr. Stewart.
Yeah, thank you. It's a really, really interesting day and lots of great talks, and I think it's really important to understand what can be done. I think that the most important thing is just try and focus on doing the simple things well. Clearly, it would be great if every person could have blood cultures. Clearly, it would be great if every person could have a biofire. But the most important thing in sepsis is recognizing that the person in front of you is sick and likely to deteriorate, that you get some kind of bloods on them as quick as you can, if that's something that you can do. That if their blood pressure is low, you give them some fluids. If you think they have a bacterial infection, you give them some kind of antibiotic, preferably into a vein, and that you monitor them appropriately, and then you make a decision about if this person is for, are they safe in whatever health center they're in? What if they get worse? Do they need to be transferred to a larger hospital? And the earlier you make those kind of higher level decisions about where the person should be managed, the better outcome the patient is likely to have. If you try and manage a person who's very sick in a health center where you don't have the resources, that person is probably not going to have a good outcome. And trying to have those conversations with the relevant nearby hospitals that could take referrals for an unwell patient is really important. But yeah, it's really, really reassuring that some of the diagnostics are increasing. I'm really glad to hear that there's some blood cultures available for the different health settings. And I think it's really important that hopefully once you start getting more blood cultures sent to the reference laboratory, that you can see what kind of bugs that you're growing, you can keep an eye on the resistance patterns, and that could potentially feed into kind of sepsis or antibiotic guidelines in the future.
Oh, thank you so much. I think this is the statement for that day. Focus on doing the small things, but doing them well. So don't cry that you're in a health center 3, just do what you're supposed to do. And if you recognize that you cannot manage the patient, please refer. Thank you so much, as Dr. Stewart, for that. Very excellent. Yes, and I'm not saying finally, but then I want maybe as just before we conclude, I'm seeing Mr. Masaba Bob is aching with a question, and then Ellie, in just half a minute, please, Bob and Ellie, because when I give the mic to my boss, then unfortunately you'll not be able to say a word. So yes, Bob, and then Ellie. And by the way,
thank you so much
just
for the
CPD points in that as guided in the chat. Thank you. Yes, Bob.
Okay. Thank you so much for the presentation. It was really so informative. Yeah, so one of the questions I had has been answered just recently. But then the second thing that I had that I wanted to know, that you have a patient who is having sepsis. And as you said, that field resuscitation is key in management of sepsis. But such this patient is having a sign suggestive of what field overload. In that case, what could you do? Then also, in a normal patient, a patient without a field overload, for how long should you assess the effectiveness of a field bolus? Thank you so much.
Thank you so much, Bob. Yes, let us have Ellie.
Okay, thank you so much for this opportunity for the panel. I'm watching you from Dubai, and this session has really helped me a lot. So I work with the emergency medical service, that is the pre-hospital care. here in Dubai. And my questions were like, should I have a patient that I suspect have sepsis and hemodynamically he's a bit of in hypotension? How much extent of fluid we can be able to resuscitate this patient in the pre-hospital setup in avoidance of fluid overload?
You want to talk about that?
Thank you.
Thank you so much. It's very interesting to hear that you're listening in from Dubai. This session has emergency medicine experts. So I will not dilute the message. I will let Dr. Jimmy respond to that. And then we shall have concluding remarks from the Assistant Commissioner. So Dr. Jimmy.
I will kindly ask that you re-echo the question. I think I missed out some aspects.
Okay, please re-echo the question so that you can have Ellie, and I think even Ben's question was related to fluid overload. How do you know?
All right, yeah, I think if that's the question. Usually for sepsis, one of the things that happens is that there's very high risk of causing cardiac overload because of the septic emboli that gets thrown into the myocardium. So you're having very high risk of actually getting a patient with fluid overload because already ongoing microinfarcts that happen that could actually risk the patient from getting right-sided or right ventricular dysfunction. And then also we have the vessels that are very porous. So there's high risk of fluid overload in a case of sepsis. And what we advise is that you give small boluses of IV crystalloids. That is between 250 to 500 mils. And then you keep reassessing the patient for fluid tolerance. How do we do the assessment for fluid tolerance? If you're in a setting that has point of care ultrasound scan, that would be a very good tool for you to use for assessing fluid tolerance. So you keep monitoring the diameter of the inferior vena cava. And if you find it very dilated or very congested, we call it plethoric IVC, you do not want to continue with your fluid resuscitation in that case. And so for every bolus that you give, at the end of the bolus, you reassess the patient and be sure that the patient is still able to tolerate the fluids that you're giving. And if the patient is not able to tolerate, then we advise that you don't continue with the fluid resuscitation. Then that's when you might actually need to use more of your vasopressors, the noradrenaline, use more of vasopressin if you have in your setting. You just keep monitoring the patient really for fluid tolerance as you give your IV fluids. Do not be very enthusiastic about fluids because of the risk that is accompanying, especially now for this patient. For me, from the very start, I give maybe 1 or 2 fluid boluses, and then I would immediately introduce in the vasopressors to support the fluids. I asked someone was a bit very cautious about IV fluids. Also, you don't want to be pressing blood vessels that are empty. Like if you're giving noradrenaline and you have not given fluids at all, you are basically like pressing an empty vessel, which will not still bring the improvement that you're seeking for in the patient. So ensure that as you're introducing your vasopressor, you have something that you're actually pressing in that blood vessel. So small boluses of fluids is very helpful. Yes, I think in addition to that, when we look at in this patient, the colloids was also introduced. IV albumin, I think in part of the slides, IV albumin was part of the medications that was instituted. This still, in addition, it kind of decreases your urge to every time give your fluids, because this is going to be able to keep the turbidity of our diastatic pressure. Yeah, thank you.
Well, the wealth of knowledge is really, really exciting. Thank you so much, dear listeners. At this point, I want to hand over to the Assistant Commissioner to give concluding remarks. But please note that we shall have a session on the 7th that is still about this important topic of sepsis. And this time round, it is going to be in the emergency department. What do you do for a patient who has sepsis in the emergency department? Please tune in on 7th for that wonderful and exciting similar session. Over to you, Assistant Commissioner. We want to know what take-home messages would you want to give us and respond to a few questions here and there. and then we shall be able to call it a day. Thank you so much.
Thank you so much, Dr. Sauda. I think I had only, there was only one question that has in a way been answered, that what do we do when you're at a health center 3 or health center 4 and you think your patient has sepsis? And that has been repeatedly told to us. Do the simple things, recognize the patient, and if you can't do anything, refer. If you can, then do the test that you have at your disposal and start appropriate therapy. With that, I'm standing in for the Commissioner National Health Laboratory and Diagnostic Services, who is unable to be with us for another engagement that she has. And she always has, we always receive full support from her. And that's what she has sent, that you have all the support that you need to support you in diagnosing your patients and also providing guidance at the center. So we are very grateful for her support. And then allow me, just as we close this meeting, to echo again what has really come out so strongly from this engagement. We don't need a different massive investment to be able to diagnose sepsis. We need to know the clinical signs and symptoms of sepsis that have already been alluded to in the presentations. We need to recognize whether we have the capacity to investigate and manage that patient early, because every second counts. And if we don't, we need to refer appropriately. So as we go home, the 3 things that I want us to take home is the time. Time is critical. Time is everything for a patient who has sepsis. And then you look around, what are the simple things that you can do, and you do it very well. And then you always have full support from the center at the Central Public Health Laboratories in terms of technical guidance, but also in terms of diagnostic support in case you're limited in one way or another. With those remarks, allow me to adjourn this meeting until our next time. Thank you.
Thank you so much. This is known to mean that the session has been closed, but officially, kindly you can put on your videos and say hello and also register. But I don't want to conclude without thanking the DG, even when he has dropped off, for his commitment, and generally from Ministry of Health, but also a round of applause to Seed Global Health, which envisions a world in which every country is strengthened by a robust health workforce that is able to meet the health needs of its population. Thank you so much, Seed Global, for being that wonderful partner. Thank you so much, all people who have logged on, and the organizers. Thank you so much. Have a blessed day.
Thank you, Dr. Stewart. The nice presentation.
Thank you.
And
Thanks so much, everyone.
Share this
Thanks.
presentation in the chat. For those that missed it, we shall be able to upload the session materials to our website. We'll share the link to the website. This session has also been video recorded, so you can feel free to also visit our YouTube channel, and you can be able to watch the session at a later time at your convenience. And should if there's any friend of yours who could have missed the session, you could still let them know about the link. They can watch at their at leisure, maybe on